I hope so. The next try. So, thank you for the introduction. When I got the title to talk about CT imaging, I wasn't sure what to talk about because it's like an old shoe and you have to tell new things. However, if you look at imaging, I would like to start with this. This is a photo taken last year somewhere in Barcelona. And what do you see? It's a thing. What is it? Maybe sky? You agree? It's the sky? And this is something else.
Or a CT scan.
It's not, I promise. The thing is, it's different. This is a wall that was there, and this is the sky in the city at the same time. The thing is, it was raining 15 degrees outside, so an image we get gives you an idea of what you expect. So this is not the truth. The truth is what you make out of the information you get. So this is the thing with all the imaging we are doing, and this is German, this means I see black. It's obvious, but this is what you have to take into consideration when talking about imaging. So what we like to do, we do imaging in order to match our assumptions. So we do something to make up our mind about the things we see. Of course, in the daily practice, this is clinical observation. We read our surrogates, senses, parameters, and we try to prove or disprove any assumption we have. And, of course, we would like to decide something. So this is the basic of any imaging. Talking about the CT, we have to ask some questions. First of all, what can we expect if we use CT? The second one, when should we use it? And when to perform, what are the indications and when to perform a CT scan? So these are things that are important if you talk about this. Before I start with that, a few things that are, from my point of view, important. So is there any bad thing about CT? The thing is radiation. Of course, you have the exposure, you have the things, you have to take it into consideration. However, it's comparable with a long distance flight. So some people who came here and going back get 2 CT scans while they are just doing nothing. What I mean is you have to take it into consideration. However, it's not that dramatic. The second one, the artifacts, these are human mates. So this is like a coiling or slipping artifact. Most of the things are there because we put them in. And the third one, the study quality, everybody is complaining about. It's most of the times it's a human factor. So if the patient is moving, if something goes wrong, it's not the fault of the patient or of the CT scanner, it's the fault of the human mankind doing this. So from my perspective, there are only bad indications or bad performance, but not bad things about the CT. So you should know when to use it. Carrying on, this means why should it be used? The CT is clear. We have a large experience. It's a broad availability. It's flexible, usable. So you mean you have a short preparation time. It's fast. It's getting faster. It's cost effective, and the patient safety is high. You can drag an ICU patient to the CT scanner. You have enough space. You can access the patient. It's a good point, I think. And of course, what is increasing, it's a modular system. You can combine it now with a lot of other methods like CT angiography, perfusion, volume measurement, quantitative perfusion, and the technology is evolving. We have detectors with more than 320 RAWs that allows, for instance, a real-time angiography, like in the Angio suite. You have real-time images. So this is the point, why should we use it? What can we expect? And this is important. This would never ever would be an MR image because it's CT. So to expect to get an image that is comparable with MR is wrong. So we have bone, CSF, brain. These are things that are very well depicted. Of course, with the big advantage of bone, CSF, brain, more or less, it's a grayscale image, and blood and air. These are the things that are really important in the emergency setup and to answer our questions. So I showed you bone, CSF, brain, blood, air. And the important thing is we have a blurring shield. And the blurring shield of awareness or of recognizing what we see is the physical principle, the resolution of the system and the quantity of the matter inside the image. Meaning, if you use X-ray, you can't get an information about the direct water content. If you use X-ray, you won't be able to have a resolution as good as an MR scanner. So you have to focus on what you would like to know. This is important. Meaning, you see it, this is a normal appearing scan, however, this is a stroke. It's a small stroke. If you have an MR, you see it white, and every even almost blind person would see it. But this is more difficult. So, what are the indications? And I think we have two different things. First of all, the plain CT scanner, the emergency without contrast media, of course, it's still the gold standard for acute head injury. All the patients who are deserving to get an MR CT scan at the very beginning, GCS less than 14, or the existence of risk factors. It's important: acute spinal trauma, acute spontaneous intracranial hemorrhage, acute hydrocephalus, and this of course includes SAH and so on, with all the drawbacks you know. So we would like to have an information about the intracranial space dynamics, just meaning we would like to know, is there something that does not belong there? Is there a space occupying whatever it is in the emergency setting? The second one, and this is later on, of course CT is still important for treatment verification and to match our observations we get from monitoring. In addition, later on it might be important for cerebral ischemia and for space occupying lesion if you combine it with something else. Something else means CTA, perfusion, contrast media, and this is true for the more vascular related things. Still acute head injury, acute stroke, hemorrhagic stroke, AVM, SAH, the secondary stroke meaning DIND, vascular ischemia due to vasospasm, and venous thrombosis. So CT might serve as a diagnostic tool as well, in addition to the first attempt just to know is that something wrong. Just to illustrate this, of course, these are the typical pictures. This looks nice, but it doesn't help at all. It doesn't look nice for the patient, but it looks nice as a picture. So this isn't anything you can use for treatment, but it's just a capability to show you the complexity you can image. The second one, which is really important, and this is the main advantage, you have air, you have blood, you have the bony structures, and you see this. And it's obvious here that something is wrong. There's no point putting a patient like this in an MR scanner because this is kind of over-diagnosing a bad condition. In this case, it's pretty easy to assess a prognosis, not due to the picture, but due to the combination of the picture along with the knowledge we have about the disease. It's the same like the first thing, you have to know the background information to draw a conclusion. Second one, acute SDH. You know this perfectly. It's really interesting, and this is one thing that might sometimes be tricky. If you have hyperacute bleeding, the blood is not white. It might be gray as the brain if you have the patient actively bleeding into the brain. And the same for the stroke. 14 days after stroke, you have the blurring. The stroke disappears. The CT might look more or less normal, and then it comes back again. This is just the small things, but this is the job of the neuroradiologist. In intensive care, it's often omitted to say we need a spinal imaging because the poorly traumatized patient quite often have a spinal cord injury or a bony injury, and this is just to show the capability. It's obvious that there's something wrong. This is a little bit more complicated. However, it delivers you in an emergency situation excellent pictures, and what is really important is the vascular imaging in a trauma setting. We are including it in the very beginning. Every patient gets a CTA at the very beginning if the patient is not accessible to clinical evaluation. The problem there is a whole body protocol gives you 7,000 pictures within 2 minutes. And everybody is there like a bird. Everybody picks its own information, and the poor guy is the radiologist who has to make the report about 3 hours later. So this is the problem we have with evolving knowledge and evolving capabilities. A nice clinical case, you know this, it's rare. However, a red eye with a dilated pupil. If you're an old clinician, you put your stethoscope on this, you hear a bruit. And the thing is, if you make a CT angiography, you see the dilated vein. This is just diagnostic for a carotid fistula. It's really rare. However, you have the opportunity to diagnose it. If you omit it and you fail, the eye is gone. And this is really important in patients that are unconscious. They can't tell you that the eye is red, or they can't tell you that something hurts. So in complexity, combining the pure morphology with a kind of function improves everything. Coming now to the other point, does CT help you to do anything in the future after acute setting? I know everybody who is motivated enough can drag out of the literature the opposite message. However, basically CT per se does not predict outcome if the CT is performed after 24 hours after the insult. Just the CT. I'm not talking about a combination of CT and clinic. The second one, it's obvious, prophylactic CT scans are not beneficial. You get your radiation, I'd prefer to fly instead of having a CT scan. And the thing is, and this is the big thing, the progression of any lesion inside the CT does not mean that you actually have to act. So the problem is when to do the next scan. And I know from the trauma guys, they say every patient, irrespective of awake, unconscious, or comatose, gets a 6-hour CT scan. And I think it takes 200 years to get rid of this, because everybody who is severely injured gets a monitoring. If the monitoring shows us something, then they do get in the picture. So this is just a policy. What I mean is you have to make up your mind when to do which image. Classical case, and this is daily practice, and it's evolving very fast. It's a classical, not absolutely typical SAH patient. You see the SAH, the ICH, and you see the aneurysm. And what is clear now, and this changed the whole thing, CTA has a high sensitivity and specificity, and it's more than it's lower for aneurysm less than 3 millimeters, but it's a high accuracy for all the others. So most of the centers, we do not need a conventional angiogram anymore in an emergency setting, even if the patient is awake. So you can operate on this, and it's not a problem because the pictures are nice. The problem with the CT, and this is what we scratched, is it doesn't tell us anything about the pressure. We can guess. It doesn't tell us about oxygenation, blood flow, metabolism, and autoregulation, and so on. So what is changing now is integrating multimodal approach, and this picture is from Giuseppe as the next one. So this is the typical stroke CT you get by now, and it's a really fast technology with a high specificity and sensitivity, showing you obviously the underperfused region of the brain. This is the CTA showing the M1 disruption, despite the fact that you don't see anything in the early CT. So this is urgent diagnostic priority. It's really stable and robust. And what it becomes clear now, with the initial CT scan like this, you can predict the hemorrhagic conversion of the stroke. That is even more important than just diagnosing the stroke per se. The second one is, we scratched it yesterday, is Xenon CT. This is a modality that gives you the option to have quantitative data. It's not that often used. You can combine it with the CT scanner. However, this is more or less restricted to a few centers because it's much more expensive and much more complicated than the normal CT perfusion. Having a thing like this, like Xenon CT, and this is going to the academic field, then you can estimate the CVF in an acute SAH stage, and these are just a study that was published recently showing that the cortical blood flow in a high-grade SAH is significantly disturbed, but this is in all the SAH patients, whereas the central CVF is higher in the low grade and goes down in the poor grade SAH, meaning that it's indicative for prognosis if you are able to make a CAT scan like this with Xenon at the very beginning. It's not a clinical routine thing, but it gives you the opportunity to get an idea what you're expecting for the future in a patient. One big issue is vasospasm, and this is a study from 2009. It's just to show you if you combine the angiography with the mapping of blood flow, transit time, and time to peak, you can actually identify a kind of problem. What do I have? Do I have a hemodynamically relevant problem? Do I have a classical proximal vasospasm? Or what is the idea? And the thing is, with a vasospasm, for instance, and we scratched it, the policy that vasospasm is just the narrowing of the proximal vessel is gone. vasospasm is likely to be a problem of the microcirculation, and therefore you're spreading depression and all these things. So it's more important to have a combination of angiography and the functional imaging using mean transit time, for instance. So we know it's evolving, and this is a study that was published showing that it's really possible to use the quantitative CT perfusion for the elevation of ischemia, and this is a 320 raw CT scan. This is a real-time perfusion map obtained within 15 seconds. So you can image the whole brain. Of course, you still have the problem radiation and information, and that's what I already said. If you have a tool like this, then you can say that the CT perfusion is an independent predictor for the hemorrhagic transformation of stroke. And for the people who are interested in, there's always a discussion, when do I have an hemodynamically relevant vasospasm? In angiogram, you say it's a 4-second delay between the arterial and the venous phase, and with the CT, it appears to be 5.5 seconds. Mean transit time means the time from coming in of the contrast meter reading either the peak or the mean time to pass the system. It's the same thing. So we're going away from the static imaging in angiogram towards the imaging combining CT morphological and functional. The problem, however, this is every day. So we have patients like this, and who is keen to transport this patient somewhere? Not me. Fortunately, I'm lucky, I don't have to do this. So the problem is 13% of the patients that are being transferred somewhere else have the risk for a secondary insult just due to the transport. So it's not, I don't know the English expression, but you have to choose either the mountain goes to the prophet or the vice versa, and the logical thing is let's move the machine, and that's what we have now. Yeah, we have portable CTs with dynamic options, meaning you can combine these CT scanners that produce really good images with the CT perfusion and with the CT angiography. So the tendency is to drag the CT scanner to the unit instead of dragging the patient. And it has been shown it's a good quality, it's safe, it protects the patient, and of course it's cost effective. And the question is, at the end, the future of CT imaging from my perspective is bright, and that's it. Thank you very much.